All right, we will go ahead and get started so we give all the time due to our wonderful guest today. I just want to thank you all for being here with us for our cell series titled Navigating Intimacy After Cancer. And many of you already know who I am, but my name is Amy. I'm the Cancer Survivorship Programs Manager here with the Coalition, and I will be helping facilitate this session along with the help of Kristen Hackbarth. So we're going to get started on a few housekeeping tips first. So if you have a question, we encourage you to put that in the Q&A box or the chat. Kristen and I will be monitoring that throughout the session today. This is going to be recorded and slides will be posted to YouTube that you'll see there in front of you. And of course, technology is not always our friend. So if there are connectivity issues, just go ahead and log back in and we will all continue where we left off. So we're going to go ahead and launch a poll right now. We encourage you to take a few minutes and answer those questions. That really gives Erin a good sense of who's here and kind of that baseline knowledge that everyone is bringing with them today. So as you fill out that poll, I'm going to introduce you. We are honored to have Erin Sullivan Wagner join us today. She is a 16-year survivor of anal cancer, and due to her treatment, she has experienced permanent side effects that have led her to develop her nonprofit called After Cancer Solutions for Sexual Health. So she serves as the executive director, and they develop educational resources to close the communication gap between patients and providers related to sexual health for cancer care. So we are so excited to have her here talking to us about this extremely important topic. And I just want to remind you all today that attendees of this session, that this is really a preview for an in-person workshop that we have the opportunity to attend at our Nevada Cancer Control Summit in August. So attendees of this session will receive first priority to that in-person workshop with Erin. So with that, I will turn it over to Erin. Thank you so much.
Thank you very much. I'm so happy to be here with you today. And the title of this presentation is Navigating Intimacy After Cancer, but it could be, titled a lot of things. Because it's not so much patient-facing, and I'm talking to a lot of you that work with patients, it could also be considered normalizing the conversation with a 30-second message for your patient. And that gives you just a little bit of a preview of what we're going to do in August when I'm there in person. So thanks, Kristen, ahead of time for just forwarding the slides so we can go to the next. Just to let you know that the mission of After Cancer is that all patients impacted by cancer be treated, or should I say have sexual health addressed as part of their cancer care so that they're able to be screened for those side effects. And to that end, we're committed to providing educational materials for the oncology professionals on how to comfortably address sexual health in the cancer care setting. So you can go on to slide number 3, and probably don't need to tell all of you all of this about why it's so important. I bet you have some ideas here, but there are a couple of things to point out. The work is so important because currently there are more than 18 million cancer survivors in the country today, and that number, shockingly, is expected to triple by 2040. We know that many of these, so over 50%, are struggling with long-term side effects from their cancer care. When we talk about female organ owners, 70% of all cancers impact reproductive organs and or the reproductive system, so to include breast. We know that prostate cancer surgeries and prostate cancer will impact a little less than half, that will have their treatment. And we know that this is the third most common concern, cancer-related concern that patients have. And just, probably most important of all is that it really doesn't matter about the cancer type. Across all cancer types, more than 50% will experience sexual health side effects, and less than 20% will be addressed. Far fewer ever resolved. So some of that probably doesn't surprise you all. So we can go to the next slide, and I'll just give you a quick timeline about after cancer, so you and put all the pieces together. So I was an anal cancer patient in 2008. And I wasn't told I would have sexual health issues. In fact, I was told I would have no sexual health issues. But after my experience, I became a life coach, really not thinking I was going to coach about sexual health, but more just the emotional challenges around the journey with cancer. And it became a voice for sexual health when I was struggling with my own journey and asked a lot of the patients I was coaching what their experience was. Almost unanimously, I would learn that sexual health issues were just so common and weren't being addressed. And I don't mean just sexual health in the form of function. I mean also with body image issues, communication with a partner, really kind of runs the gamut of emotional and physical concerns. And it was at that time I decided to be more of a voice back to the oncology community, raising awareness about what patients want the providers to know about this, and started to collaborate with clinicians. In my area in Iowa, it was the University of Iowa Sexual Health and Menopause Clinic. I worked with the medical director there and a reconstructive urologist to just understand, because these people were actually treating the patients from oncology treatment. So, our patients go back to primary care, they go back to their oncologist and urologist. So I worked with those people to understand better what not only the common issues, but the treatment side effects and the interventions that they were currently using. And I was approached by the Iowa Cancer Consortium to apply for grant funding that would actually develop the educational materials that I was telling everybody they needed, which was a great idea. So from 2016 to 2021, we worked on, and I'll show you the focus group that we put together and the learning materials that came from it. So not only workshops and courses, but conferences and learning education series like you're doing today. That all happened between those years, and we developed an implementation framework around this. And that was normalizing the conversation for patients, setting patient expectations, and referring patients out timely. Those were the components of that framework, and all of our education is based on that framework. So,
Erin,
yes, go ahead.
sorry, this is Amy. I hate to interrupt you. If you could just turn up your volume a little bit, your audio is just a touch spotty here and there, and we really want to make sure that everyone can hear you okay.
Okay, absolutely. And I'll try to project just a little bit better too. So in 2021, we had a conference. It was a full day conference that was streamed live. And I was really convinced by people who attended that this needed to be more of a national organization and not so local or regionalized. And so we did become a nonprofit organization in late 2022. So we've only been formally an organization for a year and a half. So we can go to the next slide, and I'm just going to give you a rough overview of what happened to me and when. And I tell this story not because I think it's important for you to know exactly what happened to one patient. I tell the story because there's a common thread that is really present in all patient stories, and most of them have to do with time and attention to what the issues were. So for me, what went wrong and when. On that first line, you can see when I was diagnosed, if the topic of cancer, of sexual health was normalized. For me, it was not. I had no patient expectations set around it. I wasn't told that I was going to need dilator tools or a referral to gynecology or the vulvar disease clinic or pelvic floor therapy, or possibly needing estrogen and whatever I might need from a mental health perspective. All of that started 6 months after my treatment. Was the first of it when finally some attention was on it, because I was saying how terrible this was on the physical impact of trying to have penetrative sex with my husband. It was impossible. And so what should have happened is on the bottom line. What should have happened, as national guidance tells us, is that at the diagnosis, I should have had this normalized. I should have been told that sexual health is common. Sexual health issues are common and expected, and that it's a medical issue. It's appropriate to talk about it. It's important for us to know if our patients are having issues because there are resources out there to help, and that there are referral specialties that might be needed, like pelvic floor therapy or gynecology, or mental health therapy, of course. All of that could have been done so that I would have been kind of done with that in 6 months in terms of what I needed to know to make sure that I was staying sexually healthy. Because it started after 6 months and went on then for years, what happened on that top line for me personally was our relationship also suffered. And the reason it suffered had a lot to do with me being told I wouldn't have any sexual health issues. And when I did, we didn't understand. So we didn't naturally think, oh, well, this is common. I need to, let them know about it right away, kind of thing. I didn't know why. Felt like I probably just hadn't healed yet. And when I did go back, they had never heard of it before. So they were slow to respond to give me a referral. So medical oncology referred me to radiation oncology, who referred me to gynecology, who referred me to the vulvar disease clinic, who referred me to pelvic therapy. But all of that took so much time. While we were going through that as a couple, what happened to us is first, my husband was very concerned about the pain he was causing me trying to have intercourse. And it was impossible for me to hide from that pain. It was impossible with the look on my face, the grimacing, my body. It was hard for me not to use barrier of my hands between us to keep the pain from being so excruciating immediately. All I knew is that I felt like he was hitting a wall, and all he knew was, it feels like I'm not even inside of you. So I don't understand where the pain is coming from. But it got to and that's all we could do, was explain it that way, because there was no camera and nobody could see how it was working or not working, I guess I should say. And that created the foundation for some lack of trust that we were both on the same page with this. I was doing all I could to chase every treatment out there. What was causing this? My providers didn't know what was causing it, and sent me to gynecology, who thought I had scar tissue and was working on a procedure to have that scar tissue removed, sending me to pelvic floor therapy to have dilation tools started and estrogen cream. But all those months during that time, we struggled to stay on the same page. We really went from just so celebratory after hearing that there is no cancer and I survived it, to really looking for my life back again, and him being afraid of what he was doing to causing the pain, and finally saying, I can't be the source of it anymore, and there's just nothing arousing about this. I really don't want to. And me knowing that I needed to fight for that, because use it or lose it was what I was told. And it was a very difficult place to be, to continue to find intimacy in our relationship. So what I talk to patients about, I'll go through in a couple of slides, but I want to give you the end of the story. The reason that penetrative sex didn't work for us, and never has since, was because I was told from the menopause and sexual health clinic, finally, they, cupped my hands and said, I'm so sorry that this isn't going to work. You just waited too long. There is scar tissue around the hymenal ring, and it has built up so thick that there is just no way to reverse it. What was difficult for me in that moment was I hadn't waited. I had asked and wondered and brought it to their attention. And because there wasn't a process in place, I couldn't be referred timely, and they couldn't get to the result that I needed them to get to be able to be sexually the same way as I had before. So I'm going to go ahead and go to the next slide. I just want everybody to think maybe more holistically about sex today. We're going to talk about it as it refers to intimacy, but sex being anything that is outer course or intercourse. So intercourse being anal, vaginal, or oral, and outer course being anything but penetrative sex. So if we could just kind of think of sexual activity and sexual play, maybe is probably going to be the best way for you to position this in your mind to think about how your patients might be impacted by their treatment. And when it comes to intimacy, it's not just sexual intimacy, it is physical intimacy and emotional intimacy. And we can go to the next slide. When I work with patients, a lot of male organ owners and female organ owners will kind of identify with the slide that says, yeah, I know what I think about when I think about intimacy. It's really a combination of both. And we can go to the next slide, Kristen, that talks about what it's like in a partnered relationship, sex and intimacy, and how emotional intimacy is kind of the foundation of all of that. There are components that make up that emotional intimacy in a relationship. So you look at this footstool and you can see that there are legs and there are components that kind of make up the foundation of what keeps us whole as a couple. And this was true for us. I work with patients now and have them fill this out. And we start really with a blank slate. And to say that, what are those pieces in your relationship that make you whole, that give you that emotional intimacy between the two of you? And they fill this out. And then we talk about the pieces that can be eroded when something changes in physical intimacy or sexual intimacy. For us, not being able to have penetrative sex, it may seem so odd. My friends all thought it was odd. How could you not work beyond this? You're a smart person. You know how to give and receive pleasure in other ways. We didn't know. This wasn't an expectation. We didn't realize we were in the weeds with it. We thought we were going to have a problem that would be resolved by just focusing on it. We didn't take time to work with each other and communicate well and have healthy communications outside the bedroom about what both of us might be feeling and fearing about it. We didn't go to a therapist. So what's important is to know that when something breaks down on one of these legs of a footstool for your patient, it can have an eroding effect in all areas. And it did with us. Once we stopped being able to have penetrative sex, we stopped kissing in the same way. And when we stopped kissing in the same way, which such a launch sequence for who we were as a couple, we stopped spending that same alone time together and stopped taking just little weekend trips together and spending time just looking and flirting with each other. You can all kind of imagine your relationship with another person is very complex, and all of that ended up being eroded to the point that we really crumbled in terms of intimacy. On the next slide, Kristen, I do this also with patients that aren't partners because we have to take care of ourselves too. So I'm not going to spend too much time on this, so you can go to the next slide, but we do work on sexual scripts. So what are they? A sexual script is a way you launch from a non-sexual situation to a sexual one. It's the way we express affection and love and support for each other. Oftentimes, cancer, it just disrupts all of that. And the sexual scripts need to be rewritten. We need to think about how do we launch from a non-sexual situation. Spontaneity is probably gone. That's one of the things that cancer kind of screws up. Oftentimes there is anxiety medicine or pain medicine that might have to be taken. If ostomies are involved, there's cleanliness that has to be thought through. A lot for a patient to work through. So I'm going to go to slide 11, which is kind of cancer and its side effects. And the reason I want to talk about this for just a moment, and I don't really want to belabor, so sorry if it feels like I'm hammering a point here about sexual function really is best understood in a biopsychosocial model, and cancer can disrupt all those domains. So if you have hormone changes like vaginal dryness or loss of libido, painful, pain with penetration, that can be caused by chemotherapy or radiation or surgery or hormone therapy, all of that. And that can impact our quality of life, not just physically, so not just functionally, but it can impact us emotionally and, of course, how we interact in our dynamic relationship. So going on to the next slide, it really comes down to how does this impact our sexual response? This is probably more representative of a male organ owner in terms of it being pretty linear, the sexual response. It's probably important to note here that as arousal increases throughout the response, we move through excitement, plateau, orgasm, and resolution. It's not true for everybody that we arrive at those places at the same time or with the same intensity, but these side effects from cancer do impact this response cycle, and I'm going to point out in ways that they do, and we'll come back to this slide. So on slide 13, this is probably more evident of a female organ owner. When you start with painful sex, when you start with pain with penetration, you really can't get to an intense orgasm. You can't get to a satisfying encounter when you start. You can get to a lot of decrease in orgasm, decrease in arousal, decrease in desire, decrease in satisfaction. You just can't get to a good place. That probably is more representative of what that female response cycle looks like. And so on the next slide, this is going to look a little bit like an eye chart to you, but I just wanted to show you that patients get this slide. This was developed by a physician that worked with our group throughout the All of Me project, which was the grant-funded project from 16 to 21. And this really shows you how these side effects that are cancer-related contribute to, let's say, decreased desire, how fatigue it contributes to decreased desire, and then where you can go as an individual from a decreased desire standpoint. You can get painful sex, you can get to maybe stimulation that isn't adequate or too much, but you can't easily get to a positive place. And patients do understand this, and this is sometimes used as a communication aid for providers to say, I get you. I understand that it can be kind of this complex. So this is something, it is a handout that we have for you to use with patients, and it is a handout that can be used. But I feel like I'm hammering a point here, but we'll go on to the next slide and just let you know that in terms of the types of cancer therapy that impacts sexual health, it can be surgery, and that is, whether it be a mastectomy or it's just lymph node removal, all types of surgery can have an impact to your sexual health, and radiation therapy, whether it be external beam or internal beam chemotherapy, whether it's before or after surgery, and of course hormone therapy to all of it. And I won't go into much detail, but there also are medications that also impact this. So on the next slide, so these are the types of cancers, and I only put this here so that it just drives the point home that it isn't just reproductive organs that we're worried about, but there are the GI cancers, the colorectal, anal, esophageal, gastric, you can read them all, and the GU cancers. So the GI and the GU, and that's the genitourinary cancers also. And there are, just here about 17 of them, plus breast cancer, that have a direct link to side effects that will impact the sexual response. So if we go to the next slide, I put some of the specific side effects. And you know what's true, you guys? You probably know of them. You don't think of it maybe like this, but you know of this. The side effects that impact sexual health beyond dysfunction, of course, erectile dysfunction will, we'd all think that, right? Pain with penetration, of course, too, but bowel and bladder dysfunction. I want you to, as much as you can, kind of think about your own sexual life and what you imagine it to be or hope for it to be. You can imagine with bladder or bowel dysfunction that there would be a concern, possibly a leakage, and how would that be? I mean, just not exactly is how I feel about that when I'm concerned about it. Disfigurement and how I feel about myself, and And of course, the limited mobility, think about your own sexual play and the limited range of motion, how much you use your arms, how much it's important to be able to move. And speech and communication difficulties probably isn't something that you think about so much, but being able to express what's important to you and what you want and what you need is important as part of sexual play. So we can move on to the next slide, which goes into chemotherapy, which you can imagine that hair loss would have to do with body image, and of course some of these same side effects are true for every single one of the therapies. You see some of the concerns, and of course there's the risk of infection and being neutropenic or immunocompromised. The chemo-induced peripheral neuropathy, that's important to think about how you use your hands in sexual play or your fingers and how important it is to be able to feel, and how difficult that might be and how complicated it can get for a patient who is trying to navigate that with a partner. So on the next slide is the radiation, and you can see some of the sameness of what you see in the others. I think radiation fibrosis and dermatitis might be a little bit different, but of course the weakness and the loss of fertility, that goes right to the emotional concern and stress around it all. And then in the last, going into the impact of hormone therapy. And when we go through a workshop, we actually have you all list what you think sexual side effects are, that, the side effects that would impact sexual health. And we work through it that way. So we go into a little bit more depth when we're in person doing a workshop. And then, of course, the hormone therapy, which I'm not going to spend too much time on because, the medications, because those are many, and we can look those up individually, as to what medications there are. It's just important to note that there are hot flashes and loss of libido, fatigue, and nausea and depression that can come from a lot of these medications, including vaginal. So on the next slide, it's the impact of the sexual response cycle. Everything I just went through, you can kind of see what it does here. It takes arousal, and as you're trying to move through with a heightened arousal, it actually decreases excitement. It makes the plateau stage longer. It makes orgasm less frequent or less intense, and the resolution for male organ owners much longer too. On the next slide is what we learned from our focus groups, from providers and patients. When we started this project in 2016, we really wanted to understand, we all think this is important, right? Sexual health is important in our lives. Well, why aren't we discussing this? National guidance says we should from the diagnosis on, so why aren't we? So we put focus groups together to understand all the barriers. And you can probably identify with many of these that are listed on here that you don't have extra time in the day. You weren't given any formal training on this. What are you supposed to exactly say? And it's a little bit embarrassing or awkward. Maybe the patient isn't alone, or maybe their Uncle Harry is there, or their 5-year-old son. And you wonder about privacy. And does the patient really want this talked about? And what if you did say something and the patient said, yeah, I have questions? Well, if you don't have a referral network, if you don't know where you're going to send them, well, why would you put yourself in that position if you don't know how to help? It's a difficult place for a provider to be. I want to help, I just don't know exactly how I'm going to help. From a patient perspective, because I hear a lot of people tell me that I believe my patients will tell me if they've got concerns, and I'm telling you, patients will not, and some possibly will. So I'm not going to say anecdotally you don't have stories. Unless you have connected on a much deeper level with your patient, they aren't necessarily going to feel like this is the time or the place. They feel greedy. They have burdened with God about their diagnosis. They aren't going to start talking about whether or not they're going to have a sexual, if they're going to be able to have the same sexual play afterwards. It doesn't feel like being the perfect patient. It doesn't feel like being compliant. It doesn't feel like a healthcare issue for me as a patient. I don't know what I should be concerned about it, and I believe my provider is going to guide me. And if I need to be concerned about that, they're going to tell me I need to be concerned about that. I'm not going to bring it up, and often I'm not alone. And I don't know the exact words. And one of the things that surprised me was patients said, I'm afraid of being negatively judged because of the terminology. I don't know what to say. I don't know exactly what hurts. I don't know exactly the words. I don't want to say down there. I don't think it's descriptive enough. I don't know how to explain it. And I don't want people to think, wow, can't she be happy? So the next slide goes into the implementation framework that we developed as part of the project, and that is normalize the conversation, set patient expectations, and refer patients timely. To that end, we have a 30-second message workshop. You guys are going to learn a lot more about that when I come out and see you in person. And there is an accredited course for APPs, and that course is 14 hours. It's online, it's self-paced, and it's really pretty comprehensive about all things cancer and sexual health. So you do get in there specific modules to prostate cancer and breast cancer and gynecologic cancer, head and neck cancer, but also the psychosocial concerns, how to address LGBTQ community and be welcoming and inclusive. There are 28 presentations and 16 different presenters, and it is accredited for 14.25 hours. There also are, along with both of the programs, this is the 30-second message workshop, which I am starting to do individual workshops as well, not just group. But the sexual health accredited course, this also goes into, and you can keep going, sorry, with the slide, Kristen, I'm sorry, go to slide number 26, and then we'll move right to slide 27 with the Library of Educational Handouts. So these are the types of handouts these are the topics that are available for you to use with your patient. We are not provider facing at this point. Patient facing, we're provider facing. So we give you resources that help you keep your patient. If you believe there are topics on here that topics aren't on here that you wish I would do and I would research and absolutely consider that for future, there is a handout coming on lymphedema. You'll notice that's not on here, but you'll see some of the more common concerns. There is a brochure that we use in the workshop, but for sure, the miracle of pelvic floor therapy and lubricants and what we do for low libido and how about an ostomy and navigating that and anal intercourse and fertility considerations and dating and living your best life in spite of cancer. And specific to the AYA community, where they have different milestone concerns. And an altered body image. What do we do with that? How to think about that for the patient? Rewriting sexual scripts because it's so very needed. And what about the partner? We forget about the partner. There's a partner that has their own concerns. And then Sensate Focus is an exercise that can be used with in a partnered relationship. It's a great touching exercise. You can go to slide 28, and that is, it all starts with the 30-second message. And this is what we're going to go into in more detail when I come out to see you. But this is important to understand that this 30-second message was designed because of all those barriers in place. You don't have time for more than that, possibly, especially if you're on the front line. So this was designed for nurses, for navigators, for social workers, for people that interface with the patient on quality of life side. If you do think about how you come to that role, do you come in at the diagnosis? Do you come in informed consent? Do you come in when you're talking about what's going to happen with surgery and the side effects from it? There is a 30-second message you can give your patient. And it is, of course, it depends on what your role type is to where you do enter into that conversation. So there's a lead-in line that you use. There's a 30-second message with 6 points that you give the patient. And then there's an exit strategy so that you can transition out of the message. Part of that exit strategy also, though, is knowing where would I refer my patient if they have questions and concerns. So we'll go into, and I can take any questions you have about that, but I don't want to spend too much time on it, just so that if you have any questions about anything else, we can get to it. But happy to come back to this. So on slide 29, it goes into what those components are of the 30-second message. So they are side effects. Sexual health side effects are common. You can even give some of what they are. You know them from previous slides here, and you know them probably from your own work. Sexual health is an important quality of life concern. Reason that we say that is because we want our patients to know we think so too. You don't think that alone. We know it's a quality of life concern. And that, number 3, it is a healthcare concern, not just because it's quality of life concern, but because oftentimes we're creating the issue with the treatment that we're giving you. You know, sexual health is a healthcare concern. And number 4, we have resources to help. There's no reason to hide this in the closet. There's no reason to not talk about this. There are resources, and oftentimes they are specialty resources, but we're teaching through the course too what treatments can be done in the clinic. What do you not need to refer out? What can you keep your patient longer by doing? What over-the-counter medications could be used in that situation? Maybe even a pain-focused pelvic exam, which is part of the course as well. So resources to help. Number 5 is, we get it, you don't care about it now. And this is such an important thing to say to your patient, because your patient may not care about it right now. They may not be sexually active. They may be fighting for their life. It may be stage 4. They may not think about anything but that's whatever we have to do to rid the tumor. They may think you've lost your mind talking about sexual health right now. It's the last thing on my mind. It's not on my list of concerns. By saying you may not care about it now, I get it. I wouldn't either. I tell you though, because we know from past patients, we know from studies that addressing some of these sexual health concerns make a difference on the outcome on dealing with it sooner versus later. Timing, as you remember back in the slide that showed what happened to me and when, that's very common for other patients, that we need to address some issues sooner versus later. So that's the 30-second message, along with the message on slide 30 and 31 is the brochure. And it is just a pretty vanilla brochure that allows, it's a communication aid too. It allows, and you'll learn this through a workshop for any of those that are coming to the workshop, you'll learn that this is a communication aid. You give it to your patient when you give the 30-second message. Your patient looks down and you get more comfortable giving your 30-second message. But it is something that your patient can take home, think about what their questions are, talk to their partner, possibly if they have one, absorb the information and come back with questions and concerns if you have any at a later time. So that's slide 30 all the way through 31. Slide 32 is that lead-in line, and I'll just tell you that a lead-in line is pretty simple. Has anybody talked to you about sexual health and cancer in their relationship? That's an easy thing to say. Chances are your patient is going to say, yeah, actually, somebody did last time I was here. Great. What do you remember here? And let the patient tell you what they remember and fill in the gaps where you need to be on. So on slide 33, this is a referral roadmap. And so, of course, we know if we're going to talk about sexual health with their patient, we do need to know what are those typical referral sources we're going to use? What's in network? What do we have as resources within our clinic? Ideally, we want to keep the patient, right? So we want to know who within our own clinic is able to speak to sexual health side effects. Chances are that's going to be an advanced practice provider, or maybe not in your situation, but in many models, it's an advanced practice provider that can spend more time and then bill and be reimbursed. Oftentimes that is concerning for, making sure that it works for clinic flow too. And what you'll do with this referral roadmap is we help you figure out how to navigate this. So what referral sources do you want to include? Maybe you want support groups in there. Mental health counseling is really important that you include in your roadmap. And the reason that's important is many providers want to refer to mental health counseling if they don't know who they're referring to. So we help you navigate how to have referral sources in either in your network or outside of wherever you want, maybe local, that do work with cancer patients. You want to know what kind of cancer patients do they work with, what their methodology is, what their hours are. Are they taking new patients? Do they take a patient and a partner? We ask them to develop a 3-minute video that they send to you, and you put those together. And now this is for your clinic. You use this so you know who you want to refer your patients to, when you want to refer your patients. And maybe on this also is a pelvic floor therapist that you have within your network. And in that course, we go through, when do you refer to pelvic floor? What are some of those symptoms that are successful when sent to a pelvic floor therapist, the handout you may have noticed, we named it aptly The Miracle of Pelvic Floor Therapy, because it is so many patients will have successful treatment through pelvic floor therapy, will be helped through pelvic floor therapy. So go on to the next slide, 34. What this is more, so there is more and more research that is suggesting that supports prehabilitation. And this is something I believe in strongly, that there is a way to care for your patient in a more patient-centered way, and a way to keep your patient more compliant, keep your patient, hard stop, and support your patient after treatment by implementing a prehabilitation class or a course. So it's an educational course you have before surgery, before maybe if your group was all gynecologic or all prostate or all breast cancer, or maybe it's a combination, but you could have courses or a class that is 1 to 2 hours. It's once a month. You could start however you wanted to. But at that course or class, you would have a pelvic floor therapist. You might have a nutritionist. You might have somebody who does even some mindfulness, maybe even yoga. You'd probably have the surgeon who is going to talk about, here are some of the side effects that maybe you can expect. What happens here is it not only is very normalizing for a patient to be part of a course, but their partner can come too. And this conversation between a patient and a partner can be very awkward about what is the problem and whether or not the issues are functional. Is it that that the sexual function is impacted, or is it emotional? It's helpful to a patient to have a partner present. So some of this can be normalized for them as well. And then they know what to expect. It really lower things. So this started with, or this particular program that I'm speaking about was for prostate cancer patients and bladder cancer. So it was in a urology men's health clinic in Minnesota. And they started this just because they had to, because they didn't have enough resources in their clinic to speak with every patient. So they started doing these prehab classes. And what they found is that it did lower anxiety in their cancer patients. Actually, unintended consequence here is they had a built-in support group too. These patients knew each other and continued on then after their treatment to get together. But it did normalize it. It did keep them more compliant, kept the stress levels lower, and patients. So that's it. I know I kind of rushed through everything, but I was hoping that I would leave enough time that you could ask questions and you could give me your thoughts and feedback about what else maybe you'd like to see. I have the privilege of being able to come out to see you this summer and would love to have that be impactful for you. So that's the end of the presentation, but we'd sure be happy to take questions.
Thank you so much, Erin. That's just amazing information that you've been able to share. You covered so much in a short period of time, so thank you for that. Yes. And yes, we welcome anybody's questions, comments. Perhaps you're trying to get people connected to services and you've experienced barriers. This would be a great opportunity to, to ask anything of Erin while we have her here. We have some time left in our webinar, so please share.
So I do see something about handouts. Let me speak to the handout. We are in the process of branding those handouts, so they will be beautiful. There is the opportunity for us to co-brand with you. So we are doing that with a few places where we have your logo on it as well. Some people just really are not in favor of handing out it, just have their own logo on it, and I get that. And would be happy to work with your communication groups and marketing groups just on making sure that the handout speaks to exactly what you believe too. So there are sometimes a few little changes that are made, like, you know what, we don't do coconut oil. We don't talk about that in our hand. So there are some, a possibility that you would have some changes to that, but those branded handouts will be on the website. I will commit to within the next 2 weeks, so close, but every time I say I think it's going to be this week, then there's something that something that changes, it moves it back. So I'm going to just shove it out 2 weeks and say, if you look in 2 weeks, you're going to be able to order handouts. And also, I did wanted to say just one other thing. Sorry. If you do, I do take requests. So I didn't have originally a couple of these handouts. The lymphedema is coming, not here yet. I didn't have a resource on anal intimacy. I was asked by the University of California in San Francisco if I would create something for anal receptive sex. And that's where that came from. And I can trust that if you ask me for something that your patients are wanting or that you know you would like to have as a resource for yourself, you're not alone. There are millions of others that would like it too. So we'd be happy to take into consideration anything you'd like to see.
And I wanted to mention, it looks like Kelly also said she'd be interested in attending the training. That is exciting to hear for anybody else on the call today that's interested in that as well. I've put the link in the chat to our Nevada Cancer Control Summit, which is where Erin will be holding that workshop. So you can register for the summit, and then I'll also put my email in the chat to you. If after registering you're interested in then signing up for the workshop, just send me an email and then I'll add you to that list.
And Amy, I'm going to note that there are limited spaces available for that workshop. It's only 8 people per session, and we have 2 sessions in the afternoon. And it's limited to 8 so that it can really be a good working group, and Erin can really work with the participants and coach them through developing their own 30-second message.
And I'll just ask a question here. Again, we encourage everyone, if you have a question, to put it in the chat or the Q&A. We're monitoring those. But you were talking about how you went through so many different referrals, which I'm sure is a very common theme for everybody on this call to hear that. And it sounded like from what you shared towards the end, some pretty key ones, but I'm just kind of curious if anybody on the call is really trying to help advocate for patients early on, are there some key specialists that we want to know about and really develop those relationships with? Again, you mentioned knowing kind of what services they provide, figuring out how best to refer them, but just kind of wanted to re-highlight that a little bit because I know that's the intervention piece that we all want to be able to know, what can we do with this?
Absolutely. And, you know, if you're not comfortable knowing where to send your patient, you really will avoid this topic because it's just so flat-footed feeling to not know what to do about it. To open up that, you know, conversation and then not be able to go anywhere with it. The most common referral sources are going to be, and I know I went through it real fast, but that slide that showed you the 17 cancers that are impacted where pelvic floor therapy can really make a difference. Pelvic floor therapists, they really are kind of miracle workers. So beyond physical therapy. So there's physical therapy, and that's important too, absolutely. And then there are pelvic floor therapists that within that physical therapy community. I would encourage you all to know who your physical therapists and your pelvic floor therapists are that you can send your patient to. And I think it would be great for an in-service that you have with your own group for you to find out who your pelvic floor therapists are and have them do a little bit of a, education series with your folks on the patients they see, patients they're successful treating, and when to look for it. What symptoms should I look for? When do I know to refer to you? They will definitely be able to help you with that. So in system is always a good idea first. Pelvic floor therapy is referred to so often that when I gave a presentation to a physician group, a large physician group, I really did suggest you should hire a pelvic floor therapist. Why give up the patient? You know where that patient's going. You should have one for your clinic. So a lot of people are somewhere on the spectrum of wanting to have a sexual health program, wanting to deliver sexual health services for their patients, wanting to have a sexual health clinic. And the way you start that is you know who you're referring to. Chances are you're going to refer to an advanced practice provider within your clinic who has gone through some training, who feels comfortable gathering information, taking a sexual history, maybe even who feels comfortable doing a pain-focused pelvic exam. And all of those things are talked about in the course. But that probably is the first person that you go to from a referral source is the APP, somebody that can do just more screening of sexual health side effects. So you've got an APP somewhere, so either in your clinic or outside of it. You've got gynecology, urology. Both of those are typical, common referral sources for your patient where you might get involved with devices for erectile dysfunction, where you learn about the vacuum erection devices, implants, pills, all of that goes into that. And then, of course, the mental health counseling. And the reason I went into more depth about that is that one's tough. Not always is it easy to, some systems will say, I can't even get inside my system. I can't get a referral to happen within 6 months. It's difficult to if your patient really needs help, to give them a referral that isn't going to be able to see them within 6 months. That's a difficult thing to do, to feel like you're helping your patient, which is why navigating possibly into other resources, local, maybe even telehealth, is a good idea. And I know from after cancer perspective that we're going to need to have a patient resource side of our website, and it's going to go to those kinds of resources. It's going to go to click here to find people who have either been through training or care about these types of side effects. So those are the most common. And sometimes within an organization, you'll have a vulvar disease clinic. And that vulvar disease clinic is sometimes who does the dialing. That can happen either with, pelvic floor therapist, physical therapist, or even, gynecology. Any other questions? Really, when we're talking about this topic, there really is nothing dumb about it. We're all kind of flat-footed on knowing exactly what our patients want us to even do on this topic. And it is difficult. It is difficult, which is why the 30-second message, something scripted that you always say. You could say it to the priest. You could say it to anyone not partnered. You could say it in a waiting room, walking down a hall. You don't have to feel like you're offending. You are giving valuable information. Once I had a physician say, I had a patient who was just so offended that I was talking about sexual health and I don't want him to be offended. So I went ahead and just didn't do that again. What would you say to that? And I mean, some people call this like the fifth vital sign. So what I said was, okay, well, just think about what you're saying here. If you really do believe this is a quality of life concern, just like you do bladder and bowel function, would you not tell them? Would you not set that expectation that they were going to have issues with that if you thought they would be offended by talking about it right now? Of course not. You would give that anticipatory guidance. You would feel wrong not giving. That's how you should think about this. This is just guidance of what to expect, and that you're here to help. Sooner versus later would be important.
Well, that is a perfect way to end our time today. Erin, we really appreciate you being with us and for everyone who was able to attend today. We've put some useful links in the chat for aftercancer.co and links to the resources and handouts, as well as to the Cancer Control Summit that we mentioned so that you can have access to be able to attend the in-person workshop with Erin. So again, thank you, Erin. Yes, thank you so much. And we wish everyone a great rest of your day and hope to see you at the summit in August. Thanks, everyone.